Good morning, everyone. I'm Ron Collman, Director of the Penn Center for AIDS Research, and on behalf of our leadership team, including my co-director, Robert Gross, Kathleen Brady of the Philadelphia Department of Public Health, Jim Hoxie, our founding Director Emeritus, and our great administrative team of Kate Gordon and Mandy Bell, who put all of this together, I want to welcome you to the 2021 National CFAR Scientific Symposium. We wish that you were all here in person, but such is the reality of our current world. We're excited with our speakers and our session scheduled for today. Before I tell you about the meeting and explain how it's going to run, I want to introduce now Dr. Larry Jameson, Dean of the Perelman School of Medicine at the University of Pennsylvania and Executive Vice President of the UPenn Health System. Dr. Jameson has been a very strong supporter of AIDS research on campus and of the CFAR and has a few words of welcome for you today. Dr. Jameson.
Welcome, everyone. It's a really great privilege for Penn to be hosting this 25th annual national meeting, and thank you for joining us. I want to offer a special thanks to our keynote speakers, Dr. Anthony Fauci and Dr. Rochelle Walensky. It speaks volumes with their pressing responsibilities to continue to guide us through the COVID pandemic, that they have also remained focused on another pandemic, HIV/AIDS. I also want to thank Ron Collman for his leadership of the Penn CFAR. We've made tremendous progress in AIDS research and care in the last decades, but we all know that significant challenges remain, in particular, disparities in the HIV/AIDS disease burden in different socioeconomic groups. The successes of the antiretroviral treatments have not reached all people who need them. New implementation approaches are desperately needed. Moreover, despite enormous effort, we still don't have a vaccine and we don't have a cure. These are key priorities for all CFARs, including ours. Two principles exemplified by the CFAR Research Network make it a national model for the scientific community. First, it is incredibly collaborative. Second, it is a paradigm for broad-based community engagement to help ensure implementation of screening and treatment. That commitment is reflected in this meeting, with community speakers participating alongside our scientific speakers in all 4 sessions. The past year and a half has been an incredibly challenging and tragic episode in world history. But the speed with which the safe and effective vaccines against SARS-CoV-2 have been developed is an historic achievement, and we can all take great pride in this. This scientific meeting not only highlights progress in AIDS research, but it also brings into focus how the scientific platform for AIDS research has accelerated the response to COVID-19. This starts at the top with the astute leadership of our 2 keynote speakers. In addition, much of the basic immunology knowledge and the tools that have enabled rapid understanding of COVID-19 was developed through AIDS research. AIDS clinical trials platforms became the model for COVID-19 studies. The incredibly rapid and successful vaccine program for COVID-19 was in large part built on strategies used for HIV/AIDS, including the use of adenovirus as well as mRNA vaccines. In particular, the mRNA technology that underlies both the Moderna and the BioNTech-Pfizer vaccines was an outgrowth of decades of HIV vaccine studies. Drew Weissman was recruited here to Penn as an AIDS researcher about 25 years ago from Dr. Fauci's lab, and as a CFAR investigator. His work in developing mRNA technology over the past 2 decades has been driven by his interests in AIDS research. In fact, the Journal of Immunology paper in 2000, in which he and Kathleen Erqou introduced mRNA as a vaccine platform, described how the HIV gag mRNA transfection of dendritic cells induces a potent human in vitro primary immune response. Their discovery and subsequent work are eminently deserving of all of the accolades they have received. The accomplishments of HIV research over the past 25 years have had an incredible impact. We can hardly fathom where the knowledge gleaned from this meeting will lead, or the immense contributions it will make to human health. Thank you again for joining this meeting and for being a part of such an exemplary scientific community.
Thank you, Dr. Jameson. We're excited to have Dr. Tony Fauci and Dr. Rochelle Walensky as our keynote speakers. As you can imagine, for both of them, their schedules are crazy and fluid. Amazingly, Dr. Walensky has carved time to join us live, which is a real privilege, although Dr. Fauci is unfortunately not going to be able to join us live today. In planning the symposium, we had great input from a committee here, which I won't take the time to name individually, but just to say thank you to them. First, what the committee felt strongly about was to keep our focus on AIDS research. For many of us, the past 2 years has been so consumed with COVID that it's a challenge to pull the focus back to AIDS. But at the same time, it's incredibly clear that the amazing speed of progress made in COVID was to a large extent built on the structure of science and knowledge developed in AIDS research, from mRNA vaccine platforms, which first emerged 20 years ago in the context of AIDS vaccine development, which you're going to hear a little bit about later on from Drew Weissman, to leveraging the HIV clinical trials networks for rapid vaccine testing, so much in between, and particularly the contributions of everyone here in the fight against COVID. But for today, the committee identified 4 key topics in AIDS research to address: health equity and structural racism in the AIDS epidemic, key aspects of the local mid-Atlantic epidemic, recognizing that it's not just one single uniform population of people affected by HIV and AIDS, but many different groups. Next generation prevention strategies, very exciting area emerging, and a revisiting of reservoirs that serve as the barrier to cure. We have a fantastic group of speakers, including longstanding leaders in the field, more newly established leaders, and 5 presentations by early stage investigators selected from our ESI abstract submissions by the CFARs. One principle that the Symposium Committee felt strongly about is that AIDS research is not just about the science, but it's about the community of people we're working to help. And that community input is part and parcel of the discussion and as integral to advancing the field as any of the scientific details. And for that reason, each session includes a speaker from the community to share their insights with us and participate in the discussion. A second point the committee made was that many of us feel, frankly, zoomed out. And for that reason, they recommended that we have several short presentations and emphasize roundtable discussion, questions and answers, and participation from the audience. So the presentations are pre-recorded so that we could stick to a timeline, but the discussion, of course, is live. So I encourage you to be involved, put your questions or comments into the Q&A session, and the presenters and moderators for each of the sessions will incorporate it into the discussion that we'll have after all of the speakers go for each of the sessions. So with that, I want to introduce you to Dr. Jim Hoxie, Director Emeritus, who established the Penn CFAR and led it for many years. And Jim will introduce our first keynote speaker. Jim.
Thanks, Ron. So good morning, CFARs. I was delighted when Ron and Robert asked me to introduce Tony Fauci as our 2021 National CFAR Symposium keynote speaker. Unfortunately, as Ron said, but understandably, Tony had some pressing time-sensitive issues that required his attention this morning, and he was unable to give this address live, and he will be unable to participate in the Q&A. As we all know, Dr. Fauci has had a lot on his plate the last couple of years. However, given the little extra time, gives me a chance to perhaps take a deeper dive and a more personal one into this introduction. And for those who've only recently got to know him, into who Tony Fauci really is and what his leadership, guidance, collaboration, and friendship have been to AIDS researchers nationally and especially the CFARs. I'll touch on a few things you know, but also may not know about him. So even though within our CFARs, we are all HIV/AIDS researchers, care providers, and/or community activists and members, we are a very diverse audience. And we've come to know Tony in different ways. For people like me and a few other aging PIs, CFAR directors, and former directors, we've known Tony since the very first years of the HIV pandemic. He joined NIH after completing his medical residency in 1968 and became head of the Laboratory of Clinical Investigation in 1974, where he became a national leader in immunologically based diseases. In 1980, he became chief of the Laboratory of Immunoregulation, the LIR, and in 1984, director of the National Institute of Allergy and Infectious Diseases, NIAID. Both of these positions he continues to hold today. Do the math and appreciate the gravitas of his roughly 40 years of leadership and service in these prestigious positions. Us old timers remember the first national AIDS and international meetings where Jim Curran, then director of the CDC and now former director of the Emory CFAR, would kick things off by giving updates on the AIDS pandemic with lots of bad and frightening news about how AIDS was spreading, followed by Bob Gallo, who would give updates on the recently discovered virus, and then Tony, who would describe the explosion of knowledge and understanding the links between HIV infection and the ensuing dysregulation and collapse of the host immune system. This era at NIH framed the challenges early on for what we were up against and what the obstacles were for treatment, vaccines, and cure. I want to take those of you who weren't there at that time to a slide that Tony showed in the mid-1980s, 1985, I think, as we were beginning to understand what it meant to have a viral pathogen that targeted CD4 T cells. Known as the symphony slide, it showed creatively and effectively the central role of the CD4 T cell as the conductor of the immune system orchestra. And this dared us to begin imagining the consequences of what this could mean over time for HIV pathogenesis. And this continues to be a central paradigm of the disease AIDS. Younger members of today's audience, many now established PIs, came to know Tony through breakthroughs in the late 1980s and 90s in combination antiretroviral therapy, a deepening understanding of HIV virology, good and bad, innate and adaptive immune responses, the power of non-human primate models, and the myriad of complications and challenges facing people living with HIV that emerged during these years and that are still emerging today. Many of these advances were led by investigators at NIAID and the NIH Vaccine Research Center, which was created under Tony's leadership. As an example of how many mid-career investigators in our audience likely came to know Tony during this time, I'm showing the agenda of the 2006 National CFAR meeting held at the UAB CFAR. Mike Sag is no doubt weeping out there as he looks at this. You can see the speakers of the Science Day back then, but the keynote speaker of this meeting was Tony Fauci, minus a few gray hairs. And over the years, Tony has given probably hundreds of keynote lectures to a new generation of AIDS researchers, not just on HIV and AIDS, but on emerging pathogens and epidemics, including new influenza strains, SARS, Ebola, Zika, and of course, SARS-CoV-2. He was always the measured voice of reason for what we knew and didn't know, facing tough questions with direct answers based on the data at hand, and doing his best to address how to meet the evolving problems these pandemics and epidemics posed and continue to pose. I came across this poster from a Fauci keynote address at Hopkins in 2015 on the raging Ebola epidemic in Western Africa. With all of these talks, Tony laid down the gauntlet for young scientists, probably many who are in this virtual room, to pursue the incredibly exciting career paths posed by these pathogens. To the early stage investigators of today, and especially in our CFARs, who are contributing so vibrantly to this meeting, you have had the good fortune to get to know Dr. Fauci during this time. The key point I want to make is that throughout these years, Tony has been the same person we knew back in the beginning of the AIDS pandemic. He has remained true to his love of science, the pursuit of the data, with rigor and with honesty, and with clarity as the gifted communicator he is. I'm currently one of the co-chairs for CROI, the Conference on Retroviruses and Opportunistic Infections. And in 2001, the meeting that was held last March, we had the great pleasure of awarding Tony the Ngali Mann Lectureship. Although Tony had spoken many times at CROI for his accomplishments in basic science, this lectureship, given to pioneers in AIDS education, community service, and advocacy, had special meaning for him, given his tireless efforts during the SARS-CoV-2 pandemic to be a communicator, to tell the truth, and to help guide the best next steps on the data, based on the data. Another constant in Tony's career has been his passion for clinical excellence and for his patients. He continues to make rounds at NIH, at the clinical center once a week, and he remains devoted to the training and mentoring of young investigators. The laboratory of immunoregulation that he directs has roughly 80 scientists and trainees, and he meets with members of this section once a week to discuss their progress. Every week he does this. However, admittedly, there have been times, even at NIH, at meetings I've attended, where at the last minute he was unable to be there because, in a phrase often stated by NIAID officials, Tony was doing, quote, God's work on the Hill, unquote. And that hill would be Congress. So in recognition of Tony Fauci's outstanding leadership to generations of AIDS researchers over the last 40 years, to his support of CFARs and the value they add, and for his tireless devotion to SARS-CoV-2 research and to communicating the data to the public as best he and we can, it is my great pleasure to say thank you to Tony and to welcome him yet again as our National CFAR Meetings keynote speaker.
Greetings. This is Tony Fauci here at NIH, and I'm pleased to address you today at the 2021 CFAR National Meeting Scientific Symposium. As you can see from this first slide, I'm going to be talking to you about COVID-19 vaccines and a particular view from the NIH, from our perspective here, from the work done here and by our grantees and contractors. I want to start off by showing you this cover of Science in a commentary that I wrote a few months ago in April of this year, where when people asked me, how could these vaccines have been produced and developed so quickly from the time in January of 2020 when the sequence of the novel coronavirus became readily available to people, and 11 months later, when you had a vaccine that had proven in vaccine trials involving tens of thousands of people to shown to be highly efficacious and safe. Well, as I said here, the speed and efficiency with which these highly efficacious vaccines were developed and their potential for saving millions of lives was really due to a most extraordinary multidisciplinary effort that involved basic preclinical and clinical science that had been underway out of the spotlight and under the radar screen for decades before the unfolding of this outbreak. So let me explain what I mean. We can do that in the context of the vaccine construct. First, starting with the vaccine immunogen and the work on that, which has really transformed this particular field by its extraordinary ability to induce an adequate and more than adequate immune response starts really back years ago. There's something very familiar to people involved in HIV research, and that is the concept of structure-based vaccine design, where for years, researchers involved in HIV vaccine research were using cryo-electron microscopy to get the proper, stable conformation of the HIV envelope trimer to be able to bind with and induce broadly neutralizing antibodies. And it just so happened that work that was done at the Vaccine Research Center, among a number of other centers throughout the world, happened to be where someone named Barney Graham was very much interested in respiratory syncytial virus. And what Barney did is he coupled with and joined in a collaborative effort with the structural biologists and used their capabilities to be able to get the right pre-fusion immunogen conformation of the F protein of the respiratory syncytial virus and to get the right mutations to stabilize that immunogen in its pre-fusion form, leading to the first steps towards what will be a highly successful RSV vaccine. When MERS came along, the same work was done in an attempt to make a MERS vaccine, which are still actually in the process of being developed. However, when SARS-CoV-2 came along, the technology and the capability of being able to induce mutations in a molecule, in this case, the spike protein of the SARS-CoV-2, to be able to stabilize it in its pre-fusion, highly immunogenic form, was able to get the first of the two steps together with the platform design of the mRNA to give us the vaccines that we have now that are so extraordinarily successful. This is a conformational structure of the spike protein, with the green on the top being the receptor binding domain, and has really been the basis for most, like 5 out of 6, as it were, of the vaccines supported here in the United States are using this protein conformation for their immunogen. Then again, there's the vaccine platform. We know that a number of novel platforms have been used over the past couple of decades, those involving the genetic immunization with the mRNA vaccines, viral vectors, as with adenovirus, recombinant proteins, nanoparticles, viral-like particles. One in particular, as we know, is the mRNA. And this goes back to really eloquent research going back a decade and a half to 2 decades when Katie Carrico and Drew Weissman combined to work on modifying the mRNA molecule so that it no longer triggers key inflammatory pathways, thus making it highly suitable for a vaccine platform. Another approach to that was the human adenovirus vector, which Dan Baruch and his colleagues had been working on with HIV and with Ebola, and then finally adapted it to one of the successful vaccines for SARS-CoV-2. And right here on this slide, you see the 3 separate platforms: mRNA, adenovirus, recombinant proteins with adjuvant. The immunogen that I had mentioned, developed by Barney Graham and his colleagues, Cosmicia Corbett, Jason McMillan, Andrew Ward, and others, that using the S2P immunogen. And then the multiple companies that have gotten involved. Truly an extraordinary success story, with one of them, BioNTech, already getting a full approval by the FDA, J&J and Moderna getting EUAs, and others in various stages of development. As I mentioned, this is truly a great success story of the scientific effort to address the COVID-19 vaccine. And in fact, Science Magazine in December of 2020 deemed this work on COVID-19 vaccines as the science breakthrough of the year for 2020. Let's take a quick look at the data as it evolved over the last several months to a year. First, the efficacy in clinical trials involving tens of thousands of individuals. These are the 2 papers from the Journal of the New England Journal of Medicine, the Pfizer-BioNTech and the Moderna vaccine with a 95% and 94% efficacy, respectively. The J&J vaccine, which was tested in several countries simultaneously, had a 72% efficacy in the United States, and even with the variant seen in South Africa was as high as 64%. But things actually got better, because when one looked at the effectiveness in the real world setting, that can be really summarized in this slide, in that even in the era of Delta, which is the most common variant now, about 99% of our isolates, when you look at a fully vaccinated people and compare it to unvaccinated people, the fully vaccinated people have a 5-fold less of a risk of getting infected and a more than 10-fold less risk of being hospitalized or dying from COVID-19. And if one looks not only in the United States, but throughout the world in this observational study using a national surveillance database in Israel, you see that in 200 million person years total of observation, the efficacy, or in this case, real world effectiveness of 2 doses of Pfizer-BioNTech across all types of disease, from asymptomatic to symptomatic to hospitalized to severe disease and death, all well within the 90s. Importantly, this was truly effective across all age groups, as shown on this slide, from individuals young, like 16 to 44, and those older than 85 years. The situation became complicated by the appearance of various variants, which were the result of certain mutational changes. The one that has attracted the most attention is the Delta variant, which actually now occupies more than 99% of the isolates from this country, and globally, more than 173 countries throughout the world have a substantial proportion of their isolates being the Delta or B1617.2. Why is this of significance and importance? It has to do with the extraordinary increase in the transmissibility of this variant, at least 2-fold greater than Alpha. And when viral loads are measured in the upper airway of people infected with the Delta variant, they generally are about 1,000 times higher than a comparable infection with the Alpha variant. Now, in the context of Delta, and as time passed following the original vaccinations, we began to see in our country, and I'll get to other countries, particularly Israel in a moment, a rather significant trend towards diminution in the durability of effectiveness against infection. And it's shown here, these are multiple cohorts, New York City, Mayo Clinic, with different of the vaccines, both Moderna and Pfizer. We started to see a hint of this when you were looking at effectiveness against hospitalization, with the Mayo Clinic Moderna going down from 91 to 81, and the Mayo Clinic Pfizer down from 85 to 75. However, when one looked at the situation in Israel, it was very clear that over several months, there was a pronounced diminution of effectiveness of the vaccine. And in fact, in a number of studies, and this is just one representative study, waning immunity was seen against both infections and severe COVID across all age groups, which led to the concept of the need of booster shots for SARS-CoV-2 vaccines. Now, what do boosters do? Let's take a look at some of the effect on the titers of antibodies against Delta variant. And this is a 50 microgram boost after 100 microgram primary of the Moderna vaccine product. And as you can see, the pre-booster 52, ID50, 28 days after the third shot, 872 among younger individuals, and 32 up to 706 among people greater than 65. Very similar results with the effect of the third shot booster in the BioNTech, and this is the 50% serum neutralization titer. Take a look at the blue bars, which is the antibody against the relevant Delta variant here. And as you can see, the substantial increase in titers in the younger group from 241 to 1321, and in the elderly from 123 to 1479. Now, we have done a study at NIAID of a mix and match, namely looking at the primary series, be it Moderna, Pfizer, or J&J, and then matching it against the either homologous or heterologous boost. And the results were really quite favorable when you get good titers in the homologous as well as the heterologous boosts. What about protection? Namely, what about the clinical impact? 12 days or more after the booster dose, the rate of confirmed infection was 11-fold lower in the booster group than the non-boosted group. And importantly, the rate of severe illness was about 20-fold lower. This slide, looking at confirmed infections, is a dramatic illustration of the effect of a booster compared to a non-booster when you look at confirmed infection per 100,000 people in the 100,000 risk days. And note, is it across all of the age groups? A rather dramatic slide here shows active COVID cases by vaccinated status in people 60 years of age or older per 100,000 population. And look at the difference between unvaccinated at 60 per 100,000 to those with 2 doses at 9 to 10 per 100,000, and those who got 2 doses plus the boost, down to 2 per 100,000. And again, when you look across all age groups, this is not only in the elderly, because you can see multifold lower rate of severe illness in individuals 60 and above, but also in individuals from 40 to 60. As we all know now, the data in boosters has been presented to the FDA and received the recommendation of the CDC together with their advisory committees. And Pfizer, BioNTech, and Moderna are shown on the first bullet, namely available for people 65 and older, and those 18 to 64 under certain conditions, such as underlying medical conditions, long-term care settings, high-risk places where you live. J&J, the recipients 18 and older, are now eligible for the second shot, those who were vaccinated 2 or more months previously. And eligible individuals may choose in the mix and match, which I mentioned, which booster they would like to receive, which really raises the question. And I think we will know this as we follow people over the subsequent months following the booster. Is the booster a bonus for a waning efficacy of a vaccine, or should it actually be part of the original primary vaccine regimens? And the durability of protection following the third dose will really tell us a lot about whether or not we actually have arrived at the proper vaccine regimen. And again, this is the only data that will be coming in the future. Before I close, I do want to mention, since we've been talking about boosters, that as we give boosters in our country and in other developed and rich countries throughout the world, we should not forget that we do have a responsibility, and I consider it a moral responsibility, to make sure that as we do that, that we provide equity for the availability of vaccine doses in those countries that don't have the resources to have the immediate availability of vaccines the way we do in this country. As you can see, in countries in Africa, the number of people who've received at least 1 dose is remarkably lower than in countries in North America and Europe. And the United States is putting a major effort thus far, already administering or promising over 1.1 billion doses for the developing world, with much more to come in the coming months. So I'll close on this slide, which really schematically in a cartoon manner shows where we are. It truly is a race between the vaccines, which we know are highly effective and safe, and SARS-CoV-2 virus. We still have a substantial number of people, 64 million people who are eligible to be vaccinated, who have not yet gotten vaccinated. It is up to us to get the overwhelming majority of these people vaccinated, because if we do, I'm certain that in that race between the virus and our ability to vaccinate people, that we will win the race against the virus. Thank you.
Hello. Welcome to our session on health disparities, health equity, and structural racism in the HIV epidemic. I'm Jose Bauermeister. Alongside Dr. Dolores Albarracin from Penn, we will be the co-moderators of this session. We're really excited to talk about health disparities and health equity today, not just for the scientific impact that disparities continue to have in the epidemic in the United States, but more as a reckoning and moral imperative given all the changes and social and structural challenges that we face over the past several years as a society. We have a really dynamic set of speakers today. I will introduce them briefly, and you will get to hear more about them in a second. But I will remind you to please put your comments and questions in the chat as the talk progresses, and we will be doing questions and answers at the end. So we're very fortunate to have Mr. Brown from Progeny Impact giving us a community perspective, followed by Drs. Momplaisir from Penn, Dr. Fields from Hopkins, Drs. Duthely from the Miami CFAR, and Dr. Erqou from the Providence-Boston CFAR. And so with that, I welcome you to our first session of the day and look forward to a discussion.
Good morning, everyone. My name is Taj Brown, and I am here in southeastern Pennsylvania in Chester County, and I'm so delighted to participate in this symposium today. In a few moments, you'll be hearing from several clinicians who will explore some of the consequences of structural racism that are causal to the pervading disparities and inequities still experienced by particular groups as it relates to HIV and AIDS. I've been asked to bring a community perspective. So what I'd like to do briefly is to highlight some of the intersectional issues I've noticed that are often faced by the families I've worked with. And I would like to introduce you to a therapeutic program that has been very effective in supporting children and youth who are both infected and affected, which I and hundreds of other volunteers have been privileged to work with over the past 25 years, called Camp Dreamcatcher. I've actually been fortunate to work with and consult with quite a few social justice and direct service organizations. And all of my work over the past 25 years has been about advancing racial equity and reducing poverty. I currently serve as a portfolio lead for a dynamic organization called Community Solutions, where we are working with local communities to create a lasting end to homelessness that leaves no one behind. So the lens or the framework through which I approach these matters really exists at the places where race, class, and gender intersect and interact. Now, we're all participating in today's session, so you might be able to assume that we agree that there are many well-documented consequences of structural racism. But while we're together, I wanted to highlight some of the many areas. This graph comes from colleagues at Bread for the World and the Alliance to End Hunger. And I thought it was just the perfect visualization of how interconnected these issues are. Of course, we're here to talk about disparity and discrimination as it relates to HIV and AIDS. And that would be generally categorized under discrimination in healthcare, with emphases on healthcare delivery systems and public health policy. We also know that Black, Indigenous people of color who are living with HIV or AIDS, and especially those who also are low income, are deleteriously affected by the other areas, which include living in communities that are over-policed, employment discrimination, the racial wealth divide, housing segregation, geographically concentrated poverty, hunger, and food insecurity. And although these things are not mentioned in this graph, some of the other areas that I care deeply about are environmental protections, physical safety, exposure to violence, and psychological safety. So it's important that we remember that these things are all interconnected and should be viewed as a web of issues and not considered as vacuums or in silos independently necessarily. So, all those things are traumatic, and there's a lot of trauma that comes from being in any of those conditions. And I think all of us, or most of us, probably embrace that. I really want to hone in on a theory by Rochelle Foreman-Gunter, which she calls racial trauma. And for her, race-based traumatic stress refers to the mental and emotional injuries that come when one encounters racial bias, ethnic discrimination, or hate crimes. Racial trauma can be experienced individually or systemically, as well as historically and intergenerationally. And a lot of that, according to her, comes through exposure to verbal attacks, racial slurs, racist policies in the criminal justice system, microaggressions, and lacks of cultural competencies in the spaces where we live, work, and move. So, having said all that, it is my privilege to introduce you to one of the most incredible communities, I think, on the face of this planet, that was founded by a woman named Patty Hilkirk 26 years ago. It was in 1996 that Patty decided to establish Camp Dreamcatcher because she wanted to have a place that would provide free recreational, therapeutic, and educational programs for HIV-infected or affected youth in a safe, accepting, and loving environment where they could cope and build community. So the vision of camp is to foster environments of tolerance, compassion, respect, and understanding. Our mission is to provide safe, therapeutic, educational programs to HIV and AIDS impacted youth and their families. And our core values are safety, respect, acceptance, inclusivity, friendship, and love. Some of the key components of our program model are the flagship one-week therapeutic camp session, which happens towards the end of August each year in Oxford, Pennsylvania, our teen leadership and counselor development retreats, the Emerging Leaders Program, our mentoring programs, the scholarships we distribute, the families we adopt over the holidays, the emergency funds we make available for families who are experiencing crises, and the regular HIV and AIDS education, training, and community outreach our team conducts. Of the youth we have served since 1996, 97% are Black, Indigenous, people of color, or BIPOC. This past summer, 25% were HIV or AIDS infected, and 75% were affected. 98% of the youth we have served have come from low-income households. 70% have experienced some form of trauma or abuse. 50% have lost one or both parents, and 25% or more have been diagnosed with a mental health condition. All of our programs at Camp Dreamcatcher are free, and youth attending our programs are generally from Pennsylvania, Delaware, New Jersey, New York, and Maryland. So just like any organization that focuses on young people, we talk a lot about adverse childhood experiences, or ACEs, and I'm sure most people are probably familiar with ACEs. They come in 10 categories, which revolve around abuse, neglect, and household dysfunction. What we've come to know is that 64% of Americans have experienced at least one adverse childhood experience. And according to the American Camping Association, which reaches 10.3 million campers a year, at least 6.5 million of those campers will experience one or more forms of trauma before the age of 18. So what do you do with all that trauma and those mental health conditions? Well, according to the Harvard University Center on the Developing Child, the single most common factor for children who develop resilience is having at least one stable and committed relationship with a supportive parent, caregiver, or other adult. And at camp, our trauma-informed care model really centers around sensitivity and mindfulness. We try to attract caregivers who have the capacity and skills to be supportive. That helps to shift the perspective of other people and the children, the campers. We use relationships to heal and build camp connectedness. And that also allows us to comprehend the prevalence and impact of trauma. And we use all of that to empower our campers and build resiliency in them. The 5 program goals of Camp Dreamcatcher are to improve the physical and emotional health of the campers, to offer educational sessions that explore issues, problems, and concerns that are common amongst youth who are infected or affected by HIV or AIDS, to improve the campers' perceptions of and adherence to HIV medication regimes, and to increase knowledge about HIV and AIDS, and to explore attitudes and values regarding the issues. And we also, at the end of the day, we just want to make sure the children we serve who attend our programs have the chance to feel free and have fun, just like any other kids. We're really committed to mental health equity, and we work really hard to provide a variety of opportunities that empower the young people and encourage them to attain their highest level of physical, emotional, and mental health. How we ensure a trauma-informed environment is we have environments that are physically and emotionally safe. We recognize and identify changes in our campers, especially as they return. We have predictable schedules and camp traditions that increase the sense of security and belonging at camp. We have clear emotional and physical boundaries. Kids are surrounded by caring adults and have opportunities to form positive relationships. We develop a sense of agency in the kids and self-determination so they can control their own lives. We provide resources and tools that help the campers identify and process their emotions. We also offer opportunities for them to be vulnerable and receive compassionate and caring support. And we are very sensitive to trauma triggers at camp. There are therapists all around our camp who understand the impact of ACEs and know how to support children. And we identify opportunities to help them shift from a place of isolation and stigma to empowerment and resiliency. We're all about building resiliency. We also do extensive training around DEI issues and trauma-informed responses, around awareness of the evidence of trauma and ACEs, around recognizing coping skills. We try and encourage our counselors to notice micro triggers in themselves and their campers to make that fundamental shift from what's wrong with you to what happened to you, to develop mindfulness skills, develop hope building skills. And we are particularly careful to be inclusive to the LGBTQIA community. And of course, this past summer, we had extensive COVID-19 protocols. Quickly, some of our accomplishments, man, we had 5,800 kids who have been served through our camp since 1996, and we provided 26 camp sessions, 31 weekend retreats, and 33 reunion events to children and families. 1,100 of our children have been served through our holiday program. 1,100 counselors have attended our diversity training. Our outreach has reached over 500 schools and 20,000 community folks, and our volunteers have given more than 240,000 hours of service to this program. I want to encourage you to go to our website and check out the pictures and responses we get from the kids. There's lots of incredible feedback from counselors and campers alike. And we would love for you to also please consider joining our camp. Our camp session in 2022 will be from August 22nd to 27th. And we have full medical staff, professionals, and students who volunteer the whole week like myself. So please go to the website and check us out. Thank you so much for your time.
Thank you so much for allowing me to present. And the title of my talk is Understanding the Impact of Structural Racism and Discrimination on HIV Health Disparities. So first, I'm going to start by providing some basic definitions so that we can all be on the same plane. So discrimination is a socially structured action that is unfair or unjustified and harms individuals and groups. Discrimination can be attributed to social interactions that occur to protect more powerful or privileged groups or institutions at the detriment of other groups. Racism refers to discrimination based on race or ethnicity. Now, structural discrimination refers to micro-level conditions that limit opportunities, resources, or well-being of less privileged groups. And structural racism and discrimination refers to structural discrimination on the basis of race, ethnicity, and other statuses, including but not limited to gender, sexual orientation, gender identity, and other factors listed here. So we know that ART prescription and viral suppression have improved significantly over time, and that's great news. And it's mostly due to the wide availability of antiretroviral therapy and also potent use of integrase inhibitors. So although there's been significant progress, there are significant racial and ethnic disparities that persist, particularly with Blacks or African Americans being less likely to have received antiretroviral therapy and less likely to achieve viral suppression. Hispanics are also less likely to be virally suppressed compared to white individuals. So these racial disparities are likely due to multiple factors, including factors occurring at the individual provider or contextual level. Now, historically, most of the focus of intervention has been at the individual level, particularly at the patient level, putting very little responsibility on the healthcare system. And although addressing structural barriers can be challenging, the healthcare system is a level where we can leverage resources and expertise to improve health outcomes. And this approach shifts the responsibility for change away from the patient and toward providers, leaders, and policymakers. Now, in order to put these issues in context, it's helpful to go over a research framework. And this is a research framework provided by the National Institute on Minority Health and Health Disparities. And here I'm going to focus on the last domain, which is the healthcare system, and particularly go through the different levels of influence, starting with the individual level, particularly focusing on health insurance coverage, the interpersonal level, focusing on patient-clinician relationship, and the community and societal level, focusing on healthcare policies that affect availability of services. So for this presentation, we performed a critical review of the literature and selected articles where structural racism and discrimination was measured and where the impact on HIV treatment and care was demonstrated. We excluded qualitative interviews and non-US based studies. And here we provide findings from selected articles focused on the healthcare system domain, but across the different levels of influence. So first, starting with the individual level factor, and particularly focusing on health insurance coverage. So we know that health insurance coverage and access are important and that they are associated with favorable healthcare outcomes. And that's certainly the case for viral suppression. Now in 2018, just 1 in 10, so about 11% of non-elderly people with HIV were uninsured, which is a lower percentage compared to previous years, and a rate similar to the general population, which is just at 10%. And this is likely due to the implementation of the Affordable Care Act with Medicaid expansion. However, socioeconomic and racial ethnic disparities persist. Particularly, we know that Medicaid is the single largest source of coverage for people living with HIV at about 40%, compared to 15% for the general population. And among people with HIV, whites are more likely to have private coverage compared to Blacks and Hispanics, who are more than 3 times as likely to be uninsured. And although people with HIV receiving wine-white support are more likely to have sustained viral suppression compared to individuals who are not in the wine care support system, viral suppression is higher among those with private insurance and Medicare compared to those on Medicaid or the uninsured. And this figure shows sustained viral suppression by insurance coverage. This was a study done by the Kaiser Family Foundation. And as you can see here, individuals on private insurance have the highest rate of sustained viral suppression at 69%, compared to 67% for those on Medicaid, and is much lower for individuals on Medicaid at 59% and 54% for the uninsured. So even within a network of clinics where comprehensive HIV care is being provided, there are significant differences based on insurance type. So the Affordable Care Act through Medicaid expansion has reduced disparities in health insurance coverage. However, these gains are threatened. Racial and ethnic minorities continue to have lower paying jobs and are more likely to be uninsured or underinsured compared to white individuals. And many healthcare organizations either do not accept or restrict Medicaid patients' access. There was a study published in 2019 a meta-analysis that demonstrated that Medicaid insurance is associated with a 1.6-fold lower likelihood of successfully scheduling a primary care appointment and a 3.3-fold lower likelihood of successfully scheduling a specialty appointment compared to private insurance. And this is important for people living with HIV because of the presence of comorbid conditions, particularly mental illness and cardiovascular disease. And although the majority of people with HIV in Y&Wide HIV/AIDS program receive comprehensive HIV care, access to subspecialty care are subject to those structural barriers. So now moving on to interpersonal factors and particularly focusing on patient-clinician relationships. So although cultural competency for HIV providers has significantly improved over time and has been linked to higher ART coverage, provider bias from flawed stereotypes are still prevalent and can lead to differing practices for delivery of care for patients. Studies show that Black and Hispanic people living with HIV experience substandard patient-provider interactions compared to white people living with HIV, as demonstrated by shorter visits, greater provider verbal dominance in conversations, fewer provided open-ended questions, and less psychosocial conversations. And this is important because self-reported experience of structural racism and discrimination in the clinic has been linked to lower adherence to ART and less engagement in HIV care. So finally, moving on to community and societal factors, and particularly focusing on the role of organizational culture and climate. So while the outpatient setting is an essential aspect of HIV care, there are limited data on the impact of intra-organizational, and by that I mean the clinic, structural racism and discrimination on HIV outcomes. Policies and practices within a healthcare organization are likely to be influenced by the organizational culture and climate. And first, I'm going to start by defining the organizational culture and climate. So the organizational culture captures the norms that guide behavior and quality of care. By that, I mean the way things are done, what is expected, and what is being reinforced within an organization. While the organizational climate is the collective perception of the clinic culture and how the organizational policies, practices, and procedures impact the personal well-being and functioning of workers. In other words, while culture is the values and beliefs that underlie the organization, climate encompasses shared meetings that workers attach to the organization's policies, practices, and procedures. So in the non-HIV literature, there's strong evidence that the healthcare organization, with particularly those with favorable culture and climate, have better treatment outcomes, higher service quality, lower staff turnover, and greater sustainability of new programs. And this is likely because a favorable organizational culture and climate enhances autonomy, promotes diversity and inclusion, and facilitates team cooperation and collaboration to have better patient outcomes. Now, studies describing the association between the organizational culture and climate and HIV treatment outcomes lack in general in the literature. However, 2 studies have shown a positive association between a favorable organizational culture and climate and PrEP prescription, and with a higher linkage to HIV testing and mental health care. And in general, there is a greater recognition that measuring particularly things at the health system level, particularly through the organizational culture and climate, are important. And as part of the effort to ending the HIV epidemic in Philadelphia, the Philadelphia Department of Health Equity Officer is assessing how clinic policies regarding communication, representation of marginalized identities and demographics throughout the clinic's power structures and other policies and practices affect HIV care. So in summary, For people with HIV, most of the evidence of structural racism and discrimination and its negative association with HIV treatment and care comes from the individual and the interpersonal levels. Objective measures of structural racism and discrimination within clinics are lacking and need to be developed. A favorable organizational culture and climate has resulted in health outcome improvement for other chronic diseases, and whether improving the HIV clinic culture and climate results in improved viral suppression among racial and ethnic minorities remains to be tested. Finally, I'd like to acknowledge my research team members and also members of the Philadelphia Department of Public Health. Thank you so much.
Good afternoon. My name is Errol Fields, and I'll be describing briefly a qualitative evaluation of community-based HIV and STI testing program tailored to Black MSM in Baltimore City. I have no disclosures. As we know, Black, gay, bisexual, and other MSM are disproportionately burdened by HIV and STIs in the US. Black people are only about 12.5% of the US population, but as shown in the figure here, accounted for 38% of the nearly 24,000 new diagnoses among MSM in 2019. Similar disparities are seen across bacterial STIs, including gonorrhea, chlamydia, and syphilis. The figure here illustrates disparities in primary and secondary syphilis in particular, where Black MSM accounted for nearly 30% of the reported cases among MSM in 2019. While the etiology of these disparities are multifactorial and certainly cannot be blamed entirely on access to testing, Black MSM face several structural barriers to HIV and STI testing that really compound disparities by contributing to delayed treatment and ongoing transmission. These include experiences of intersectional stigma in their communities and the continuation of these experiences in healthcare settings through implicit bias from providers and other healthcare workers and structural racism. Black MSM are more likely to live in areas with the lowest density of HIV prevention services, and accessible services are often lack the cultural and structural competency needed to engage this priority population, like, for instance, lacking the ability to create a clinical space and therapeutic environment where Black MSM feel comfortable disclosing their sexual behaviors to their healthcare providers. To decrease rather than compound these disparities, we need more testing modalities for Black MSM that really circumvent these barriers. To address this gap or begin to, our team developed a community-based testing strategy tailored to Black MSM in Baltimore City. And in this talk, I'll discuss a qualitative exploration of our participants' perceptions and experiences with this testing program as compared to their prior clinic-based testing experiences. This community-based testing program was called the Safe Spaces for Sexual Health program. It was a community-informed, status-neutral testing intervention combining online outreach with mobile band testing and ran from February 2018 through April 2019. As shown in the schematic below, we recruited MSM from online venues through direct messaging or online advertisements and directed them through a study website to testing on a mobile van that was circulating in areas of the city with high virtual congregation on dating apps, as well as high community viral load in the physical spaces where the van was parked. We offered rapid HIV testing by finger prick, syphilis and confirmatory HIV testing by venipuncture, and self-collected genital and extragenital specimens for gonorrhea and chlamydia screening. Our recruiting and online outreach and advertisement strategy for the testing ban was informed by a community advisory board of Black, gay, and bisexual men who largely informed our online advertisements shown here. We recruited men for semi-structured interviews following their participation on an HIV testing and STI testing on the Safe Spaces mobile testing ban between October 2018 and January 2019. The eligibility criteria for the interviews were the same as the criteria for participating in the Safe Spaces testing, mobile testing study, and these included identity as an identity of cisgender male identity, having had a male sex partner in the past 12 months, living in Baltimore or the surrounding area, English speaking, and being at least 18 years of age. Participants who agreed to participate completed a 60-minute semi-structured interviews in a private office at some point following their participation in testing on the ban. These interviews were audio recorded and transcribed verbatim, and the transcripts were double-coded until there was group consensus and then analyzed using a constant comparative approach that was assisted by NVO12, which is a qualitative analysis software package. The participant characteristics are summarized here, including demographic characteristics and the HIV and STI test results for 25 MSM who participated in the qualitative interviews shown in the middle column. And for your reference, the 151 MSM in total were tested on the mobile testing ban in the third column. For the interview participants, the average age was 32, but ranged from ages 21 to 65, and the majority identified as Black and gay or bisexual. 40% of the participants were living with HIV, including 2 individuals who were diagnosed with HIV for the first time or on our mobile van, and nearly 25% of the interview participants were diagnosed with 1 or more bacterial STIs. So our findings were that participants generally described a preference for the safe spaces testing van compared to their prior clinic-based testing experiences. 3 main themes related to this preference emerged from the interviews: having a greater comfort with staff and the testing environment of the van, a feeling of greater privacy and greater assurances of confidentiality, and then easier accessibility and efficiency of testing on the van compared to testing at clinical settings. In the next several slides, I'll share some participant quotes to really illustrate these findings and these themes. The first theme was this greater comfort with the staff on our van compared to clinic-based testing spaces. Several participants described experiences with staff being rude, unpleasant, or distracted in clinic-based testing sites, and they felt that these staff members were often not very personal or didn't really care about their needs. One 25-year-old participant described how uncomfortable he feels seeking sexual health services from his primary care setting because it was not inclusive. He says, "Yeah, man, I would feel less comfortable being honest about the number of sex partners I had with them. And just by some of their language use, you can tell they're not as welcoming. I guess the care providers there are mostly MD docs, and a lot of them are older white male people who just some of the language that they use is a little bit archaic. Yeah, I feel like the way that they talk and ask questions sometimes makes me feel a little bit judged or feel like I can't be as open and honest about my answers." Comparing this experience to the Safe Spaces testing van experience, he goes on to describe how the testing van experience was more comfortable because the staff were more diverse and it was within the community where people lived and worked. He says, "I feel like there might be certain people who have identities that aren't represented in the workforces of places like the hospital. Like maybe people of color, they might feel more comfortable getting tested in a place where there's out in the community, out where they live, out where they work, when they feel a little bit more at home or more comfortable. I think the workers in the van were people of color, which I think might make them feel more comfortable to see people that have their identities working there." A second theme was the perception that the Safe Spaces testing van provided more privacy and assurances of confidentiality than some clinic-based sites. Several participants noted that they liked the van because it was inconspicuous and discreet. A 21-year-old participant has commented that this made the testing experience less stressful. He says that there was a feeling of anonymity. Like just generally, I would say that the van is less stressful. I feel like the van wasn't marked. Nobody really knows what you're doing. Like if you don't know what the van is, then it's a lot less stressful than going into a hospital where people are like, "Oh, what are you in here for?" As another participant described, this discretion was important because of the continued HIV stigma of Black MSM experience. He says, "I think it appeals to usually the Black gay man just because, like I said, it's more discreet. And a lot of people don't want everyone to know their business. And HIV is so big in our community, so it's just like, I think it does appeal more to a Black gay man." And then a third theme described by participants was easier accessibility and greater efficiency of testing services on the testing van compared to clinic-based testing due to location in multiple areas of the city and availability in evening and weekend hours for on-demand or walk-in testing without an appointment. Now, a 32-year-old participant illustrates this point by saying, "So a lot of times when there's STI testing and there's a brick and mortar spot, they only do testing from a certain time to a certain time. Like, I love the fact that you guys do a mobile unit, that you guys have night shifts, because a lot of people, if they want to get tested, they have jobs and aren't off until 5. Quote, I have to call off for work just to go get tested and everything else." So in summary, participants really generally preferred the Safe Spaces testing modality because it mitigated many of the barriers to testing they've encountered in typical clinical settings. It was a more comfortable, inclusive, and welcoming testing environment. It was discreet with more privacy and a perception, at least, of greater confidentiality than in clinic-based testing sites. And there's also increased accessibility with a variety of hours, and really the mobility of the van allowed the van to be and to meet people where they were in their communities. But they also have some limitations. First, there's a potential for social desirability bias. The interviewer was a frequent staff member on the van, so participants may have been inclined to express more favorable responses about the testing environment. Second, the study only looked at one modality of non-clinic-based testing and didn't compare acceptability and feasibility of alternative strategies. And third, the results of this analysis may not be representative of Black MSM populations outside of Baltimore. But despite these limitations, these findings have some important implications. They suggest that innovative, population-specific, and locally relevant strategies can reduce barriers for Black MSM to access HIV and STI testing, and that community-informed, community-based testing strategies like these have the potential to reach Black MSM currently not engaged or perhaps under-engaged in testing services. This lower threshold to HIV and STI testing also leads to a lower threshold to entry into HIV care and prevention cascades. Future research and program initiatives should really focus on the development and evaluation of population-specific and culturally competent approaches to identify an optimal suite of testing modalities for Black MSM who are not being reached by some traditional testing venues. Thank you very much. I'd like to acknowledge my co-authors, in particular my long-term primary research mentor, Dr. Jackie Jennings, as well as collaborators at the Centers for Disease Control, the sources of funding, including the CDC Minority HIV/AIDS Research Initiative, which is the primary funder for this project, as well as the Johns Hopkins Center for AIDS Research. I'm happy to and looking forward to the discussion period for more questions. Thank you.
Greetings, everyone, and thank you for joining our presentation today. Scratching Below the Surface, an exploration of challenges faced by ethnic minority women with HIV in the US who are at risk of falling out of care and the opportunities for intervention design. My name is Lunthita Duthely, and I'm an assistant research professor at the University of Miami. I have also listed my contributors, Drs. Alex Sanchez, Professor Jonelle Potter, as well as research assistants, Varsha Prabhakar, Emily Montgomery, Megan Brown, and Tanya Thomas. We are all with the University of Miami School of Medicine. I'll begin with a brief background to our research. Patient-level challenges such as mental health or substance use disorders, as well as structural-level factors such as discrimination and stigma, have been documented as barriers to achieving optimal health for racial ethnic minorities with HIV. As part of formative work to design a mobile health or mHealth intervention customized for racial ethnic minorities who are at risk for falling HIV care, we measured and examined the relationships between both subjective and objective measures of adherence and known barriers and facilitators to HIV care. For our methods, baseline cross-sectional data were collected from a convenient sample of African American, Haitian American, and Hispanic American women receiving HIV care in a safety net clinic in Southern Florida, which is a US HIV/AIDS epicenter. Women were surveyed regarding antiretroviral adherence, both rating and days taken, depressive symptoms, HIV-related stigma, and resiliency. Recent HIV viral load, mental health, and substance use history were extracted from the electronic medical record. Parametric and non-parametric descriptive statistics such as proportions, chi-square, and medians, as well as bivariate and post-hoc analyses, the Spearman coefficient and the Kruskal-Wallis, tested the relationships across and within groups using SAS Studio 9.4. A total of 50 records were analyzed by racial ethnic group, as well as preferred language, which is a proxy for acculturation, which is linked to health outcomes. The first table summarizes the comparisons by linguistic group. 37% of all participants had a recent documented mental health or psychiatric condition. English speakers significantly more than others. 14% overall had a recent history of drug use, which occurred most commonly amongst English speakers. Creole speakers were found to have the lowest rate of viral suppression. The highest was amongst the Spanish speakers. English speakers self-reported the lowest rate of antiretroviral adherence. Table 2 shows us the linguistic group comparisons of medical mistrust. Generally, lower adherence assessed both subjectively and objectively correlated to higher mistrust across all linguistic groups. Across linguistic groups, participants reporting always taking their antiretrovirals endorsed significantly lower mistrust. Within linguistic group, Creole speakers reporting always taking ARV endorsed significantly lower mistrust compared to other Creole speakers who did not take their ARV always. Finally, we present the racial ethnic comparisons of various assessments and antiretroviral adherence. Overall, higher depression correlated to viral non-suppression. Depression also correlated positively and significantly to stigma and negatively to resilience. Haitian American women endorsed significantly highest level of stigma, African Americans the lowest. Amongst Hispanic Americans, higher stigma correlated significantly to viral non-suppression. Amongst African Americans, lower resilience correlated significantly to viral suppression. To conclude, amongst this cohort, significant relationships were found between both objective and subjective assessments of adherence and HIV stigma, depression, resiliency, and medical mistrust, both across and within linguistic and racial ethnic group. Findings can inform equitable, culturally and linguistically competent interventions designed for women at risk of falling out of HIV care. These results underscore the nuanced differences by both racial, ethnic, and linguistic groups. Our ethics, disclosures, acknowledgements, and contact details are listed here. Thank you.
Good afternoon. The topic of my poster presentation is variations in statin prescription among veterans with HIV and non-cardiovascular disease. As you know, people with HIV are living longer thanks to antiretroviral treatment, the success of antiretroviral treatment. And with that, they are having increasing burden of age-related diseases. One of them is atherosclerotic cardiovascular disease. In addition to the increased burden of cardiovascular disease, they also are noted to have worse outcome when they have atherosclerotic cardiovascular disease compared to non-HIV patients. In addition, it's noted that there is some gaps in quality of cardiovascular care that HIV patients receive compared to non-HIV patients for various reasons. But the existing data on statin use in people with, living with HIV in the US population, especially among veterans, is limited because some of them are not up to date. And some of the studies are small, so they are underpowered. And studies have not looked at variation between different facilities in quality of cardiovascular care, specifically in statin prescription in patients with HIV or their predictors. So the objective of our study was to identify patients' level correlates and also interfacility variations in statin prescription among veterans with HIV and non-atherosclerotic cardiovascular disease. So our method was, we took veterans with HIV and existing atherosclerotic cardiovascular disease, meaning coronary artery disease, ischemic cerebrovascular disease, and peripheral arterial disease that received care in 130 VA medical centers in the years 2018-2019. So this is based on VA data. We assess cross-sectional correlates of any statin prescription in the electronic health record system. And also we investigated, we used a two-level hierarchical multivariate logistic regression model. We looked at individual level variables and facility variables in the regression models, and they were included as fixed effects. We also included the VA facilities themselves as random effects in the regression models to account for clustering within facilities. We calculated odds ratios. We also calculated median odds ratios, which assesses inter-facility variation, accounting for patient characteristics that might be different between facilities. So in the second column here, that's the characteristics of the veterans included in the study. 9,608 veterans had non-cardiovascular disease, atherosclerotic cardiovascular disease. And here we see the overall characteristics. The mean age was 64.9 in those taking any statins, and or a little bit lower, 62.9 in those not taking statins. And as you see, of the 9,600 people, only 67% were on statins, 67.9%. The expectation is when somebody has atherosclerotic cardiovascular disease, they should be, all of them should be on statins. And so 67.9% is for the overall. When we see some subgroups like blacks, for instance, we see the percentage of statin prescription is lower, meaning they are even getting lower statin prescription rate compared to the average. Other people that have lower prescription rate will be those with depression or those with history of substance use. On the other hand, those with history of diabetes have significantly higher percentage of prescription, 82% there. Similarly, those on antiretroviral therapy have higher percentage of prescription of statins. And those on CD4 having higher CD4 count or viral suppressed viral load, they all had higher statin prescription, which is consistent with what we expect, where people who are engaged with antiretroviral treatment and having their viral load suppressed are expected to be also following up with cardiovascular care better. And of course, diabetes is a strong indicator for statin prescription. And so when physicians see diabetes, they are more likely to prescribe patients on statins. The second table below is multivariate predictors. That's odds ratios of statin prescription in these participants. So this is mutually adjusted for each other. So as you see here, some factors are strongly related with statin prescription and some factors are associated inversely. One of them is black, for instance. They are about 30% less likely to prescribe statins. On the other hand, those with diabetes are significantly more likely to be prescribed statins. In addition, I would note here, those on antiretroviral therapy are more likely to be prescribed statins, as you see here, also very high. Another group of people that are more likely to be treated with statins were those with coronary procedures. So those were also more likely to be treated with statins. On the other hand, people who had non-coronary atherosclerotic disease, like stroke, like ischemic cerebrovascular disease or peripheral arterial disease, they were less likely to be treated with statins. Here on the last column, we look at the variation across facilities. And as you see here, not all facilities are prescribing at the same rate. Some have high prescription rate and some have lower prescription rate. The 10s and the 90s percentile runs between 55% and 78%. And when we use the median odds ratios to compare the prescription pattern for individuals between two different facilities, making sure that the characteristics of the individuals are accounted for and the characteristics of the facilities, we still found about 20% variability between the facilities. So two similar facilities are likely, about 20% likely to have a different prescription pattern of statins for two similar individuals at the two different facilities. So that's expressed in the median odds ratio of 1.21 with the range here. Another thing we noted was that this variability between the statin prescription pattern also was more marked for Black participants, for those with non-coronary atherosclerotic vascular disease, and also for those with history of drug use. So, for instance, Blacks were not only less likely to be prescribed statins, but also the prescription pattern was more likely to be different between facilities, similar for illicit drug use, people with history of illicit drug use or non-coronary atherosclerotic vascular disease, showing the difficulty of managing some of this group of patients and the differences in capacity between the facilities, suggesting that. In conclusion, in an analysis of large-scale BA data, we found suboptimal statin prescription and significant interfacility variation in statin prescription among veterans with HIV and non-atherosclerotic cardiovascular disease, particularly among Blacks and those with history of non-coronary atherosclerotic cardiovascular disease or history of illicit drug use. And by identifying these care gaps and the correlates, we aim to provide policymakers and practitioners with more insight on how to improve cardiovascular care for people living with HIV. Thank you.
Thank you very much for these absolutely wonderful, brief presentations. And we are really curious about lots of aspects, and we have a limited time, but let's start with some questions, and the audience has paused for speakers. Dr. Brown, one question that we have is, could you expand on the mindfulness component, please? How was it actually implemented?
Yeah, thank you for that. We really try to talk about mindfulness during our counselor training activities, which involve a series of boundary breaking and team building exercises, really focused on helping the counselors to be present and being aware of what they're feeling in the moment without interpretation or even judgment, just really being centered and focused. And then we also integrate a whole vast series of therapeutic activities, everything from acupuncture. Each kid gets a 20-minute massage, and counselor gets a 20-minute massage during the week. And we also focus on things like breathing exercises. There's guided meditations that therapists take us on. And all the kids go through yoga sessions. So we really just try and promote mindfulness as a way for people to be aware of what they're feeling, how that impacts their space, and how that impacts other spaces.
Excellent. A question for Dr. Momplaisir is, what are the main barriers to identifying the impact of the structural clinic level factors on patient outcomes?
Yeah, that's a great question. And I think it's first by taking a step back and understanding or really asking, how can we measure structural racism and discrimination at the clinic level? And how can we, as a healthcare system, work on improving first of all, the measurement for that, and also addressing them. And the data that I presented with the patient-doctor relationship was somewhat surprising to me, because I know that we've come a long way, in a good way, to improve the relationship between the patient and the provider, but there's still disparities that exist and persist. And I think a lot of it are due to unconscious bias and the measurement of the notes being longer for white patients compared to Black or Hispanic patients, or having more of a shared decision-making type of interaction for white compared to racial minorities. It's one example of ways that we can proactively measure those things. But I think it also comes with when the patient walks in the door, how is their reception? How do they feel when they walk in? How do they feel when they leave the clinic? Globally, how, compared to, for example, what Mr. Brown mentioned with the camp, like how can we create an environment where that's trauma informed, where patients can come and feel good about themselves, can feel good about the team using the right pronouns, or not having biased judgmental conclusions about who they are and their behaviors. So it's hard to sort of objectively measure, but I do think that we need to do a better job to take away the responsibility from the patients who's already struggling with a lot of social determinants and putting the emphasis on us and thinking, okay, what can we do differently to provide equitable care?
Thank you. Dr. Fields, one of the questions that came in is, do you use GIS methods? How do you select the most efficient site? And is this done, in an ad hoc way, or do you use experts, or what's the method?
Yeah. Thank you for that question. It's a great question. We actually did use GIS methods. Specifically, we looked at community viral load by census tract and really overlaid on top of that the areas where there was high congregation of folks on geosocial networking apps. So we looked virtually to see where people were physically located when they were signing on to the apps, and that there were high levels there, then overlap with high areas of community viral load. That's where how we decided where the ban would go. And that was really based on not only sort of physical location, but time of the day and day of the week as well.
Excellent. Dr. Duthely, do you think the negative association between adherence and medical distress reflects overall distrust of medications, or is it more of a distrust of the medical care team or the provider?
Yeah, that's a great question. I mean, I think that it's something that I should probably, delve into with our data, or in terms of surveying our patients. But in general, the medical mistrust scale that I use is divided into 3 subscales. And so you could see the difference. So for example, by the ethnic group. So in some groups, the lower scores or the higher mistrust scores were more about the providers, and the higher mistrust scores in some cases were more about their feeling of how they may have been treated differently from others in the clinic. But generally, I would say that, in the South Florida area where we've got a mix of cultures, predominantly Latin American, Spanish-speaking people, and Creole-speaking people, outside of the English groups. And so, there's a historical context, right, in terms of, going back to Tuskegee for African Americans and for Haitian Americans, when the HIV epidemic first hit the US, and just being from having a Haitian origin was a risk factor.
Dr. Erqou, your poster session talk was very, very intriguing to us. I was wondering if you could speak a little bit about where are you going next in this area of research, particularly as it relates to health equity? So how do you think about health equity framing in some of the research that you're doing?
Thank you for the question. I was expecting to see some degree of differences as we have seen before. It was more significantly more than I thought that I would see. I see it as one way of targeting patients to improve cardiovascular care. So the next areas I'm looking at is on actually how to compare different facilities that do well and that don't do so well, and see the ones that are doing so well. What are they doing that's well? Maybe there is a social worker that's involved that's able to address some of the social issues patients have. As you notice, it's not just race was a factor, but there was also history of depression, for instance, was an important factor. And one thing that I noted, if it was not clear when I was speaking, is there is also variation in how different facilities handle them, meaning that it's not that everybody is doomed not to do so well in this aspect. Some facilities are better equipped, and so we can learn from them is what I'm thinking, and so that's what I'm seeing as one way of going forward.
I love that approach, learning from the agencies that are doing well in certain aspects and replicating that. I am mindful of time. I don't know if the panelists have any other questions they want to ask one another, and if not, we will close the session, but I want to make some space for the panelists to be able to have a dialogue before we do so.
I would just like to co-sign Mr. Brown's comments about the training as a camp counselor at Dreamcatcher about 15 years ago as a medical student. It was incredibly sort of informing to be able to have those skill sets to be able to relay to the campers and really provide them with the support as a counselor to sort of deal with challenging emotions and feelings that came up during the camp. And just kind of, it was just an excellent experience as a budding provider and researcher at the time to sort of get that exposure and be able to sort of care for that really vulnerable group of patients and people.
Yeah, thank you, Dr. Fields. I was going to recognize you as a camp counselor, so I'm glad you brought it up.
Well, thank you all for attending this session. It was really informative, and I feel like we could end up having a much larger discussion. I hope we do offline. So with that, thank you so much for attending this session, and we look forward to the next one. See you soon.